Good morning, ladies and gentlemen. My name is Gabriele Vaccaro. I come from Italy, Bologna. I would like to apologize for not coming. I had some problem. I would also thank the University of Surabaya for inviting RHEIN83 to present new solutions for overdenture on natural teeth and impaired root and overdenture on implants. What I'm going to talk about is new instruments that allow us clinics, as practitioners, to make the prosthesis system easier over implants, and also allow us to restore and replace impaired teeth. RHEIN83 is a brand that exists since 1983. And we developed and are still developing solutions to solve cases that in other ways usually ends with an extraction. The focus of my speech today is to treat this kind of patients with an unconventional system. The tooth diagnosis in this case is easier to do. Usually we pick up all the teeth and place 4 implants for an overdenture over implants. But these patients didn't accept this solution. First of all, we have to decide what kind of teeth we are facing. Are they good teeth to maintain? Are they hopeless teeth? Eligible for extraction? Are they questionable? So, when do you consider a tooth hopeless? Why we extract a tooth? We decide this when we have persistent symptomatic endolesion, like this, that it's not possible to treat by normal root canal therapy or by surgery. When we have severe periodontitis, this tooth has a vertical mobility and a grade 3 mobility in transverse. When we have severe loss of our tissue, fracture, vertical fracture, or combination of the previous situations. So remember that around the teeth there is the periodontal ligament, that it's not only a connection system between the root and the bone and the alveolar bone, but it has inside receptors that gives information about sense of touch, pressure and pain. We have 3 hand fibers in the coronal part of the ligament. We have Meissner corpuscle in the intermediate, and we have Ruffini receptors in the apical part of the root. All this system is connected with the central nervous system, connected with the masseter and temporal muscles, and connected with the temporomandibular joint. And this system works together, combined, giving information concerning movements and position. This is a very precise and fine system that records movements as little as 1 or 3 microns. When we use the cardboard to check the occlusion, we use a 40 microns thickness cardboard. So this system efficiently encodes the tooth load and transfer this to the central nervous system. It is demonstrated that signals from periodontal ligament coming from receptors, together with proprioceptors in muscles and tendons, play an essential part in fine contour regulation and coordination of the jaw. So remember that when we lose a teeth, we lose all this function. Important sensory motor function is lost or impaired when these receptors are removed after the extraction, as these authors stated in their studies. So remember that tooth extraction is irreversible. We can replace an implant, but no one will replace this sensory system. When we have residual roots, exhausted tooth, think before extraction. They may serve as abutment for removable partial denture or overdenture. So let's go back in the clinic, in the practitioner office. These female patients, 50 years old, came with pain and sensitivity in this region, in the upper right cuspid. She felt pain and movement. After X-rays, we found a fractured teeth. This made the tooth useless. We couldn't use it anymore for giving stability and retention to the partial removable prosthesis that she was wearing. The normal solution that a practitioner could take is to extract this tooth, add a new performed teeth, and place the clamp in the forward tooth that in this case is a lateral incisor. So we are even in the aesthetic region. But if we put a clamp in the lateral teeth, we are in the front, in the face of the patient. This is after the extraction of the fractured part of the crown. We made a crown lengthening regarding only the soft tissue and the gum. Prepared the tooth for the root canal therapy. This is after the proper root canal therapy. And this residual root now is free of infection, with no periodontal problem and no endodontical problem. So it's still useful. It is a valid abutment for our overdenture. What I want to suggest you is to, before extraction, is to think about this kind of solution. I have this direct post that I can put inside the root. So I prepare the post space using the specific drill, the Muser burr. Prepare the post, making its surface rough and changing its shape in order to make it fit as more comfortable as possible inside the root. It's better to adapt the post to the root than the opposite. I have to put the post as apical as I can, because I have to reduce all the crown movements and all the crown cantilever. This is what I have in the denture. What I have to do now is to cut away the clamp, add performed teeth, and in the bottom of the prosthesis carve a space big enough to host the metal housing for the female retentive cap that I'm talking about. There must be a space big enough to have no interference with the metal part of the housing. We obtained one important result, that we lowered root to crown ratio, because we placed the post inside the tooth. So now on this tooth there is no cantilever due to the crown or to the clamp retention to the crown. The retention is lowered to the gingival level. On the top of the sphere of my post, I can place relining directly on the prosthesis, as we saw before, one of the female retentive cap. At the first step, I choose a softer one because it has properties that allows me to restore and make the residual root function in a better way. What I would like to focus on different kind of female retentive cap that we can find. Usually we used for a long time friction rigid materials, rigid female cap that worked by friction, only by friction. There was no expansion, no movement inside the female cap. So the only reason that took the female cap in its place was the friction with the equator of the sphere. In a short time, the wearing surface reduced the diameter of the sphere, so it was the clinician, the practitioner, was obliged to change it and choose a smaller one year by year. Now, I would like to suggest you to evaluate this kind of female retentive cap. We used a new kind of material, elastic material, like nylon, Teflon. It has a thicker layer than rigid materials, and most important of all, they have an elastic memory. So this works in a different way. The retentive area is bigger than the one we had in the friction system, in the rigid system, because the bottom of the female retentive cap is elastic. So when it overcome the equator, it compresses. Because of its memory and elastic, it comes to original shape when it overpasses it. So we have a friction area. After the compression, it returns to its memory, and we have a retentive area. So we have contact, friction, and retention. Moreover, further on, the sphere of this system is cut on the top. So there is a space on which the soft retentive cap can be pressed by the occlusion, by the swallowing, by chewing, during chewing. So we have a movement, a vertical resilience the prosthesis has over the gum. I choose the green cap for the first load that I apply on the residual root because it has extremely elastic retention. It's easy to pick off by the patient. It has a good adhesion, good contact surface on the sphere. So it has a physiotherapeutic action because it absorbs occlusal and transverse stresses, reducing the load direct on the root. It makes the load progressive. It betters the root to crown ratio, as we saw before. The post is shorter than the crown. The post sphere is shorter than the crown. So we are at least what we are doing is the rehabilitation of the periodontal fibers, and most important of all, we are maintaining the pressure sensitivity, maintaining this and confirming this to the whole prosthesis. Coming back to the practitioner clinic, to the practitioner office, we made a hole here to host the metal housing for the female retentive cap. Now mix the powder and the liquid resin to fill it. In the mouth we have covered the post with the female cap and protecting the gum and the undercut of the post with a piece of glove. I cut a piece of glove and put the female cap just on it. The liquid resin here will cover and block the female retentive cap. Place it in its place firmly and ask the patient to close tight the mouth and put the teeth in contact, because we have to give the exact position, and the pressure must be developed and distributed over the gum and over the natural teeth in the same way. Remove it, clip it up and clean it, polish, and it's ready to be delivered to the patient. And this is the end. We have no more clamp here, no clamp here, and this is the final situation. This prosthesis changed its function. It's not only a piece of resin just put on the gum, but it's connected with a sensorial system. It is the residual roots that we have saved. we were able in 1 hour and a half to give an answer to all the patient requests. She asked an intervention with reduced prices, with rapidity, aesthetics, precision and functionality. She asking us to solve also the other 4 clamps she had. So, reducing our costs, reducing patients' costs doesn't mean that we are providing a work uglier, not functional and not aesthetical. So, same system applied on another situation, the one we saw before. We have to do root canal therapies, post-fixation on the roots, as we saw, all resin prostheses she was wearing for a temporary arrangement. This is 75 years old patient wearing an old removable partial denture, here, resin tooth, mixed with natural tooth. The only natural tooth that was in occlusion was this cuspid. So all the system worked with two different ways. The resin tooth pressing over the gum and the natural tooth. So he had two sensitivity system, sensorial system, the natural tooth and the gum. And the wearing rate on the upper tooth were different, because here we have resin against resin, and here we have natural tooth enamel against resin. This is the situation. As we saw before, now we know well enough the technique. We have to cut this crown, restore and decide which tooths are eligible for extraction and which are eligible for remaining in the mouth. Cemented, once we have cemented the post in the mouth, we check it on the X-rays. On exhausted tooth, so now we have to decide resilient system or a rigid system. The resilient system, we saw this before, allows a mechanical movement according to the gum, to the pressure over the gum that the removable partial denture usually do during chewing, during mastication, and during masticatory cycle, and during swallowing. So carve a hole in the bottom of the prosthesis, of the old prosthesis, and cover the post sphere with glove dam. I prefer the glove because it's thinner than the usual rubber dam. This protects the gum from the hot coming from the resin. Place the soft, the gummy, the green female cap. Check that there is no interference with the prosthesis, with the patient prosthesis. Choose veneers or preformed teeth to apply directly on the female cap. Wait the resin harden. And so, using this system, we are giving to the bone around the root an adequate stimulus that determines bone growth. This is an implant observation. This is an orthodontical observation. This progressive load made a benefit for the periodontal ligament. Now we changed the occlusal aspect of the prosthesis, because we have all resin teeth, all resin surface. We have no more mixed enamel and resin, but we have all the same surface over this denture. This makes all the system works in a better way. This is the bottom of the prosthesis with the female cap relined directly inside. And this is the final solution. In 1 hour and a half, we had a temporary arrangement for this patient. We educated and motivated this patient to take care of these residual roots, because he learned how important they could be for a removal for partial denture, because without this there will be no more retention or stability for this denture. And now it's easier for him to brush, to clean, to take care of all this situation, easier than this. After 6 months, he came with the gum healed, completely healed. But we saw some sign of decay, still decay. So I asked my technician to prepare a cover, a gold cover for this part of the root. And this is the ending. He is a dancer. Saturday night and Friday night he usually go to the ballroom, and he asked to apply a jewel on his upper denture. We made a new one, up and low. Other situation, exhausted tooth, a fixed prosthesis that doesn't work anymore. It was no more possible to fix it again. So we converted the existing fixed denture in a removable one in one seat, in the same seat. The technique you saw before, direct pin, and this is the final situation. Another case. This is periodontal exhausted. In the previous case we saw the loss of substance of hard tissue, of dentin, that couldn't make us possible to fix again the fixed prosthesis. Now this system was periodontally impaired. There was movement. The root has lost more than 70% of the periodontal ligament. So take the post, make the root canal therapy, take the post, make it rough, fix it in the mouth. We picked the previous fixed denture and reline directly in every crown. In every crown we reline the female retentive cap. The green cap, the softer one, were put on the frontal, in the incisor and the cuspids, because they were the most impaired and injured tooth in a periodontal aspect. In the strongest tooth we put the pink female cap that were the strongest. And so this is the temporary arrangement. In half an hour, in 1 hour, we solved this situation. In the meantime, I took an impression of the post cemented and sent it to the lab that built up this prosthesis that I could deliver to the patient. Another situation, like the one we saw before. This fixed denture, all fixed denture, has the same problem. Injured teeth, decay in the abutment that couldn't make me possible to fix it again. The middle line was completely wrong. So we removed this, we made root canal therapy where necessary, and fixed temporarily, and fixed the post in every root. In the fixed denture, in every crown corresponding to a root, we fix the female retentive cap. This time I used the yellow one because every teeth was periodontally good from a periodontical point of view. The only problem that the root had, that the abutment had, was due to decay. 3 roots of them were good enough to cover with a customized post. So we took an impression with castable pin, dirt it with an impression adhesive, a light body and a putty to take impression that was developed by technician. And we had a castable attachment, a castable crown, root crown over the tooth. These are the residual roots with direct pin, with direct post. This is the final situation. And we have a perfect platform on which we can, this is the impression, on which we can apply our denture. This is the final denture. The patient didn't agree the implant planning. She had economical problem. She wanted an economical solution, but without impairing his aesthetics expectation and his functional expectation. We have a denture, a removable denture, an upper removable denture without the plate. And we had the occasion to change aesthetics because we centered the middle line. And we have a better outcome from functional, aesthetical and perioral aesthetical point of view. Another solution for a temporary arrangement. These tooths were exhausted. The abutment were completely decayed. They were carrying the clamps for the retention of this partial denture. This patient instead was eligible for implant solution. We planned a sinus lift on the right side and the placing of 8 implants. 4 in one on the left and 4 on the right side. But we needed a temporary arrangement for the healing period of 6 months for the sinus lift. So we saved the 2 central incisor roots to maintain a removable partial denture. Always the same procedure. We make the endo treatment, the root canal treatment, post space, fixing the post, rubber dam with soft, with pink female retentive cap, relining the denture that the lab prepared for me, and this is the meantime. We can use it in the meantime that the patient is going to heal the osseointegration and the sinus lift. So we used this system to project overdenture over natural teeth. We saw the sphere, the use of the sphere over natural teeth. The same system, the same project we can have in overdenture over implants. This is a sphere that we saw that we are using since a long time. Recently we developed a new kind of abutment coming directly from the sphere. We cut the top of the sphere, we cut the neck, and we put a thread all inside the sphere. So we had only the functional part of the sphere in a lower space. And this is the result. We can use it in the same way we did with natural teeth. These are 4 abutments. This brand produces the same abutment, the same prosthetic platform for every kind of implants. These are 4 implants placed in the jaw. As we saw, now I'm not using the rubber dam, but I'm using specific ring, plastic ring, to protect the gum and the abutment surface. I place the pink female cap with the container, and as we saw before, natural teeth, we always use the same procedures. Make hole big enough to have space for the liquid resin inside. Place it directly over the steel housing, And this could be done in chairside procedures. The same situation with two implants. This time I'm not doing this directly, because I apply the pick-up transfer, the snap-on transfer, that works this way. Take an impression, fix the analog, the specific analog on the pick-up implant and the pick-up transfer. Oh, this is another kind of pick-up to take impression. And the lab prepare the prosthesis over this, as usual. This kind of abutment can be used also to project a bar, because I can use the thread inside, combined with a Seeger. The Seeger is a ring opened in one side. Its diameter in the bottom is a bit smaller than its diameter on the top. So when it passed the equator, it opened its space, and it comes to its original shape after it passes the equator. We need it because we invented it, we projected it, because we have a space, we made a space between the framework, between the framework that goes over the abutment, a space because we don't want any friction between the framework, the metal framework, and the implant. There must be any friction, because the friction that I have here is transferred to the implant. And this space is filled with a Seeger bar, with a Seeger ring. The screw that we have on the top, we need it only to fix it, to put the Seeger in its place. How does it work? This is the space that allows the framework to have a movement without the Seeger. So we are safe from friction and from tension transferred to implant. This is what in implantology is called passivity. This is a special instrument that fits the Seeger in its right position, and then the screw on the top. I stress again this concept. There must be no friction, no contact between the metal bar and the head and the platform of the abutment. And the screw put on the top doesn't touch the wall of the container. The only retention is due to the Seeger bar, to the Seeger ring. How it works in the mount. This is an animation, a design. It has movement. It's put on the equator. It has movement. Then I put the Seeger on, and it doesn't move anymore. And the screw and the cover screw put every piece in its place. Another clinical case. I have 3 implants that I want to connect with a bar. So I screw the equatorial profile abutment on these 3 implants. The thread is made to house a screwdriver, a square screwdriver. This is in the lab, and the lab gives me a bar that is designed this way. This is the housing for the Seeger bar, for the Seeger ring. This is the instrument we saw before to put the Seeger in its position. The Seeger in its position. This is pressed down. This is pressed down. This is not yet in its position. With the instrument, with the tool that I used before, I have to press all the perimeter here to make it overpass the equator. And the covering screw. What I want to stress again is that there is no contact between metal and the head of the screw. This is the framework under the prosthesis, and this is the final smile. Another situation. In the lab, the technician prepared me this the bar and with castable components. Another situation again. I have this, and he was using two removable denture. I fixed 4 implants in the lower jaw, and after this must be the final result. How to do this? The 4 implants with a snap-on transfer. This with a clip, with a click, it's put in its place. Take the impression and use the analog to clip on the snap-on transfer. The impression ready for developing, and the model. It goes to the technician that gives me this. So I put the framework, the bar, over the 4 implant, and it has still movement. Then I use the Seeger ring to fix it. With a special tool, I put it in its place, press it, and make it overpass the equator. And then screw it with a covering screw. And this is the final bar and the final solution. So we had in a few hours with simplified system that doesn't require special technologies, or the lab doesn't need to acquire special machines or new technologies, because he only has to use castable components that needs a usual laboratory machines for metal cast. And the upper part is made in an easier way. And in a couple of hours, even for direct load implant case, can be done in a couple of hours. Before we say goodbye, I would like to explain why we had this kind of abutment. Because we wanted to avoid this kind of problem. Fractured screw, fractured implant, fractured abutment and implant, losing of the thread inside the implant, and the equator profile system allow us to avoid all this, because the retention is not mediated by the screw, the final screw, but everything is due to the Seeger ring. And for a problem like this, we developed this kind of tool, an extractor, that allows us to get into the thread tube and unscrew the broken screw with this grip, with this glove. So I would say goodbye, thank you for listening, and hope to see you again in Bologna next time.